Good morning, everyone. Thank you so much for joining us today. I guess as a teaser, what's going to get you to my workshop? I have a panel of people that are in Nigeria, and they'll be joining me via Zoom. I feel that they have a better grasp of everything that's happening. And so for half of the presentation, I'll be doing just a quick overview of what they do, the community-based primary healthcare program, how it started and where it is now. And then the other half is actually going to be a fireside chat with our partners. I have some questions where we explore how things are going right now, and then looking into the future for sustainability, how they're going to grow, and things of that nature. So I think it'll be a good split. You're not going to hear me talk the whole time. We're going to have a partner session and kind of chat with them about how they're looking into the future. So I'm really excited and hope to catch some of you in my session.
Sanu, which is hello in Hausa, the native tribal language in Adamawa State, in eastern Nigeria, where our colleagues and friends support a village health worker team for our partners. I'm Rob Thames. I'll be facilitating this session, and my role is I lead the administrative arm of GHAP called GHAP. We try to close the gaps. So all the things that are related to sustainability, things we take for granted, like leadership, governance, financing, and particular emphasis on community-engaged care, which is what this session is really all about. We're finishing setting up a few technical things here to get our colleagues in, and we've already heard an introduction of Prosperity's background, which is also in here, in case you forget. But let me just start by saying we're very blessed to have Prosperity lead us today in this session. And I'll give you what's not in her bio, because we've had a chance to spend some intimate time with Dave and others when we were traveling. But Prosperity is an avid traveler, but more importantly, she's a wonderful travel companion, which is really important when it takes 4 airplanes and a 4-hour off-road drive to get to meet our friends and colleagues in Adamawa State, in eastern Nigeria. I will also add, because some of you how many are familiar with this particular area? Some of you are, obviously. Some of you may only hear in the news certain things. You know it's in Africa, you know where Nigeria is, okay, it's the eastern side, but I want to just orient you a little bit. Some of the locals call this area the bush because it's so far up, beyond infrastructure, transportation, communication, all those kinds of things that we take for granted. What you might have heard in the news too that kind of grabs your attention is in the sort of 4 corners area where Nigeria, Niger, Chad, Cameroon all come together, it's Lake Chad. Lake Chad, unfortunately, due to climate change, is about 1/10 of what it was in size. That's also a region or area where a group called Boko Haram kind of comes out. And so that is a concern that gets our attention. And our partners are very aware of that, so are the folks who live there, and they help manage that and our safety too. So we're good with that. But just to kind of orient you in the world where that is, because that is something that even if you've never been in that area, you might have heard about. So this is under real challenging conditions. Folks are doing some wonderful work. So what you already heard about Prosperity is what a wonderful professional she is, but I also want to say that she will introduce the team that you'll hear about. But a fun fact about Prosperity is that she's the 4th of 5 in her family, and their names are Prince, Peace, Praise, Prosperity, and Profit. And by the way, Prosperity likes peanuts. She had some comparison. She brought a ton back, didn't she, Dave? All our suitcases were full because she likes the groundnuts there in particular. So when I say This is what I have to say about that. People, please promise to prepare a pretty passionate applause for prosperity.
All right, thank you so much, Rob. That was excellent. All right, thank you guys so much for joining me today. As Rob mentioned, I'm Prosperity. I'm a pharmacist by training, and I'm really excited to be able to talk to you about my experience being a part of the GHAP team earlier this year and meeting with the amazing community health worker program and the people that do it and that make it run. And so for the time being, we will explore some of the things they've been able to do in the community with low innovative technology, as well as just low innovative tools that are easy to come by, but that make a large impact in the lives of the people. So we'll spend about 20 minutes getting an overview about these things in the area of malaria, malnutrition, family planning and childbirth, as well as diarrhea and cholera. And then we'll move on to the partners fireside chat. As I mentioned, the goal is to talk to them about what they're doing, think about how we scale up, and then think about sustainability for the future. And so without much ado, I'll go ahead and get started. This is the workshop agenda. I already talked about all of this, and so I'll skip ahead to the learning objectives. And so the first thing we hope to do is explore the role of community health workers in health promotion. But they're not just doing health promotion, they're also doing health education, they're doing health advocacy, and they're able to help with disease prevention in the communities that they serve. The second learning objective will be to gain knowledge about these cost-effective, low-tech, and sustainable tools that are used in promoting health in these regions. And then the other two objectives we'll get into more with the fireside chat that we'll have with our partners, and that will be to explore sort of these imbalances that exist between the available healthcare needs of the people and the resources that they have to meet those needs. It doesn't always match, and so how do you fix that? And then lastly, we'll explore the intersections between one's health and the availability of other community resources like water and food and livelihood, and how that all comes into play to actually, either give you more chances of being healthy or less. And so those are sort of the four things we'll try to explore through this conversation today. So this is a bit of an introduction. So Global Health Ministries and the Lutheran Church of Christ in Nigeria, they signed the Memorandum of Agreement in 2010. So this program has been going on for a while. And the goal wasn't just to come in and help with the healthcare system as it was. They weren't trying to build more clinics, build more hospitals, and things of that nature. They were following a different approach, which is a community-based primary healthcare system. And this was built using the seed scale model. And I wanted to take a moment to talk about the seed scale model, just a little bit, because it is a foundational piece of what we do. And the seed scale model offers a process by which every community, if they decide, can drive change in their community once they make a decision to do that. So other models might propose that you need to have money already. You need to have skilled workers already. You need to have a structured government already in place to be able to make change in a community. But the seed scale model thinks otherwise. It thinks that we should invest in human energy, so the people and the community. And once they make a decision that they want to change where they are, and they have the context of the change in mind for their local setting, they are actually able to make a change happen. And so instead of waiting for everything to fall in place, you really need the human energy, and then you can start to see the change happen from there. So you start from humans, and then you go to other resources as they kind of come along the way. So that is really important to keep in mind when we go into the details of what we're able to do. So the program itself fully launched in 2 villages in 2012. And so I already mentioned that a GHAP team went to Nigeria earlier this year, and we were able to observe the growth and the challenges within the program, and that's a part of what we're going to discuss today. To start us off, I wanted to give you a picture of Nigeria and where we work and the state and where it's sort of a bit of a history about it. So you can see that it's on the northeastern side of Nigeria, that's Adamawa State, and it's bordered by Borno and Taraba and Gombe, and it's actually also bordered by Cameroon. That's where the red is, and that's another partners country that we work with. And so that's the part of Nigeria where it's located. Nigeria as a whole is a populous country, and so just in Adamawa State alone, there are about over 4 million people since the last estimate that they did. The capital city is Yola, and in the capital city, there's probably about maybe 400,000 people, but the rest of the people actually are pretty spread out across the state, and they live in pretty rural areas, and the majority of people are farmers, and they kind of live outside of the city. And they're also pretty diverse. They're diverse both in ethnic groups and in religion. So for religion, there's about 30% that are Christians, or 55% or so are Muslims, and there are about 15% that are traditionalists. And so because of this diverse culture, they have over 78 ethnic groups, although there's about 20 major ones, just in one state. And so when you think about healthcare delivery in a place like this, language often might be a problem with having so many different ethnic groups. And so the main language that is paramount for healthcare delivery is Hausa. And English is the official language for like government documents and the government offices, but Hausa is really what you need to know to be able to provide healthcare to a majority of the people in the rural areas. And then when you look at the history in terms of the healthcare system, it used to be that it was more missionary based. So when the missionaries came in, one of the colleagues said it was Bible in one hand and a stethoscope in the other hand. And so they built sort of that initial healthcare delivery system. But it's kind of moved to be that the government does a lot more of it now, and the missionary clinics are more supplemental for the rural areas. So the governments are often in the cities, and they have the bigger hospitals and things like that, and then the missionary clinics are more supplemental for the rural areas. However, the quality continues to decline, and the reach also is not as fast as it used to be. And so this is why now there's an investment on preventative health care and seeing if there's other approaches to be able to give health to the people that live in those rural areas. Here we have a diagram just to depict the state of the LCC and health institutions, looking at different time frames. And so here you see when LCC and health services was at its peak. There were about 23 dispensaries, 3 maternity wards, and 29 health posts. A dispensary is different from a health post in that the dispensary might have a trained healthcare worker available, and they're the lowest level of healthcare service delivery. A health post, on the other hand, usually doesn't have any trained person in there. And then in 2010, when the memorandum was signed, there was about 8 dispensaries that were functioning well, 1 maternity ward, and 2 health posts. And the numbers have shifted since then, so that in 2022, there's about 22 dispensaries, 2 maternity wards, and 4 health posts. And while this might seem like a large number, or maybe not, it's woefully not enough for the amount of people that they have to reach, and the places they have to serve, and the villages that they have to serve. And hence the idea behind the community-based primary healthcare program. Digging into the community-based primary healthcare program, a main component of it is the village health worker. And so I wanted to provide a definition for what a village health worker is. And when you think of a village health worker and you try to look at the WHO definition and kind of put all the stuff we know together, the definition is that a village health worker, they're individuals that are carrying out the functions related to healthcare delivery. They are trained in some way to be able to help in that specific health context that they're working in, but they're not formally or professionally trained with any certificate in healthcare. And so ideally, they should be members of the communities where they serve. They're selected by the communities that they serve, and they're answerable to the communities for their activities. But they might not be directly connected to the healthcare of the larger healthcare, so maybe the government or whoever is delivering the healthcare. So this is really important to understand their role and how they are selected by the community members. Another thing that I thought was interesting is that village health workers and community health workers are interchangeable in some places. So maybe I think in India, the village health worker and the community health worker is the same person, according to the WHO. But in Nigeria, it's slightly different because community health workers actually have some sort of medical training. And so they're called community health workers. And that's why they chose the name village health workers so that you can have a distinction within the local context. But just in terms of like, if you look at it at a bigger picture from the WHO perspective, they would consider them community health workers. Hopefully that makes sense. I wanted to make that clarification. For the village health worker program to work, community mobilization is essential. It's critical to work in accordance with the cultural norms to ensure that there's buy-in and community ownership. Again, we are following the seed scale model, which posits that the community owns this change that they're about to make. And so within the villages, each partner community that LCCN works with, the villages meet together and they select a village health and development committee. And these community members are tasked with upholding the commitments that they make to be a part of the program. They are also tasked with assessing each program and looking at the impact on their community. In success, we found out that over the years, success depends on making sure that the village head and the local government, whoever is the head, whether it be a Muslim head or a Christian head, they buy into the program. And by buying into the program, we are more likely to succeed because they, again, have ownership of it. So I thought this was interesting to add here because, again, you can work in silo, but I believe in kind of looking at the literature as a whole to see if what you're doing has a basis for it to work. Like, are we just working in silo? Or are we doing something that has been shown to work? And it was reassuring to see that from the WHO level, when they look at the African region and other lower middle income countries, there is agreement in all the studies that have been published that community health worker programs have a great potential in strengthening health and community systems. And so actually the WHO has put the community health worker programs as part of their strategy moving forward for changing healthcare delivery systems around the globe. So we're not doing something in silo, we're doing something that's supported by studies and literature and things of that nature, which is really good because we want to do things that are supported by studies. And here I just wanted to highlight the year-to-year growth of the village health worker program within LCCN Health in Nigeria. I just chose a few years to kind of show you how it's changed over time. And so from the time the Memorandum of Agreement was signed in 2010, there was an operational team and the training was set up. And then by 2012, our mobile leadership team was established. And there were 2 sites, in Waka and Dingai, they were set up. And you can see that some communities joined at that point, and then some village health workers were enrolled at that point. And then year to year, you see additional communities joining and additional village health worker trainings happening. And so word of mouth has actually been the biggest way to spread what we do. As a community is thriving and they're doing better, other communities that are neighboring, they see them and they're like, we want that in our community as well. Again, that piece of ownership comes in and they approach the team and they say to them, we want to have what the other community has. And that's how they've been able to grow from one community to the other. And year to year, that growth has continued. So this is a very great example of a successful program. All right, so shifting gears, we're actually going to look at the actual low-tech innovations that are driving health promotion in Nigeria. And we're going to explore stories that matter in the area of malaria, diarrhea and cholera, malnutrition, as well as family planning and child delivery. The first one is malaria. And the big innovation here, and the thing that has made the most difference, is the insecticide-impregnated mosquito net. The village health workers are trained to then train their community members on using this net appropriately. There's also training on education on clearing any stagnant water that is in the area. And some of them are also trained to be able to conduct malaria testing and treat it with the accessible drug ACT. The impact here is really the biggest impact you can ask for, and that's reduction in mortality. And so by doing this, we see that there's death rate of children under 5 and their mothers is lowered sufficiently. The next one is diarrhea and cholera. And so we have been able to concurrently run a water program with the community-based primary health care program. And this means that there's availability of clean, portable water. The village health workers also promote hand washing techniques, like the tippy method that's in the picture there. And then there's also education on community and personal hygiene. And so most of the families have moved from defecation in just the villages and in the bushes to defecation in improved toilets and things of that nature. And it's making a huge difference in their water supply, food supply, and just general hygiene to be able to reduce the occurrence of diarrhea and cholera. And the impact here is that across the board, there's less spending on medical care. And the children are able to stay in school because, again, you know, these diseases are some of the ones that keep children away from school when they get sick. So this is a big impact for this. And the next thing to discuss is malnutrition. As we've heard, you know, for children to get above the age of 5 in some of these communities used to be a big struggle. And so the goal was really, how do you get children to live and make it past the age of 5? A big problem used to be malnutrition. But now the village health workers are able to train the community on how to use upper arm measurements using the Chatter Street. They're able to educate them on balanced diet and what that looks like. They're able to educate mothers on exclusive breastfeeding for at least the first 6 months, as well as competency with oral rehydration solution, which you can use if a child is having malnutrition and maybe they're having diarrhea, you can use that to help them. So these are really impactful, very low tech, easy to make tools that they're using within their community. The impact is that now we're able to detect a child that is showing signs of malnutrition early, and then the women are able to remediate that. And that helps make sure that our children are staying and growing beyond the age of 5. And finally, family planning and child delivery, another big part. Again, the theme for this is healthy child and healthy mother. And so the mannequins are an example of a tool that is used for educational programming on safe delivery in the case of emergency. And I say in the case of emergency because the program trains the women to not give birth at home, to try to get to a clinic and try to get, you know, so that's part of the education. But also there's times when there's an emergency. So then this program is used to train them on that. And there's also family planning tips that are offered to the women. And this impact is that you have safer mothers and safer children. And women of childbearing age are able to pace child delivery, which we know is better for the woman and the family, and not having children too close together. So these are some of these tools that we wanted to discuss. And I think the Archbishop summarizes the sentiments that a lot of the community members feel in saying that some of the village health workers have never been to school, but now they are our teachers. And so I think you pause to kind of take that in, what that means for the community, that members of the community are able to learn to be able to teach us how to be better and how to promote our health. And this is magnificent, I think. And the Archbishop is someone that's respected in the community, and so for him to make statements like this, it helps build the program because other villages want to be a part of it as well. All right, so then one major aspect of the program is continuous training and supervision, because once you start something, you have to think about sustainability, you have to think, how do we keep it going? And so there's different levels of training that happen. For the newer communities, it would probably be a little bit more educational. We're trying to teach the village health workers these tools that we've discussed, and then they go on and teach their community members. And then over the years, as they become more confident with the tools that we've given them, the support that they get is becoming more administrative and just more touching base with them, logistics, making sure that they're still using what you taught them. And then the last part is supportive. There are some of the villages that have been a part of the program for a really long time since it started. The women are well versed in all these things, and so you provide more support to them and maybe update their training from year to year as needed. And then they also become trainers of newer villages, and so that's kind of how the circle goes, which is really great to see. And the last thing I have here is incentives for the community members. So it's really important to incentivize the community to be able to continue to push along and make sure that they do these. And so the incentives can come in the form of a financial or non-financial incentive. And so for the village health workers, one thing that they described when I was there and would chat with them is this sense of purpose and the pride in being able to get the community respect. Because again, being able to learn these things elevates your level in the society, and so you have a sense of purpose in what you're doing. Another thing is that they do gain health education and valued skill set that they can use for themselves, for their family, and for their community, which is an added benefit. And then for the women, some of the programs also have over time done micro-loan programs where they have a community pot of money and they can put it in, and then women can use it to do other things for their livelihood, and they're able to use that to better their life and that of their family. And so that is another incentive for them to continue to be a part of the program. And then for the Village Health and Development Committee, which again is an essential part of this program, they are able to discuss with the team and bring in more water projects to their community. I remember when we were in Nigeria, when we came to the first village, one of the Village Health and Development Committee members gave us a big envelope with money, and he said, we are ready to commit to this program because the way the water program works, we need a commitment from the village before then GHM will supplement to be able to build like a well or something for the village. And so it was great to see the enthusiasm that the guy had with the money to say we are committed to this program and we want to see it happen in our village as well. And so this is an incentive for the committee because they have that sense of pride in bringing something to their community members and things that will better the lives of everyone with them. And then for the men as well, some of the women, there's also education that is provided for farming because again, most of the villagers are farmers, and we're able to supplement the education that they get and help with other things for their livelihood, and that's another incentive for them. So that's enough of me talking, and thankfully looking forward to the fireside chats with our partners and to think more about the future and where we go from here.
So I'm going to say some applause. Do it. I'm going to ask Dave, Dr. Dave Thompson, to join up here. He's on the panel. And while we're at it, he's next to Kumsu, who is one of the team leaders there. He won't be out live, but just to keep him straight, if you want to write this down, this one's Kumsu, he's standing, this one's Dave.
All right, thank you so much, Rob. So you can see here are some of the partners that are joining us. So I have Dr. Dave Thompson, and like I said, Dave is the father of this program. He was there at the beginning when they went to do that memorandum of agreement. He knows everything about the program, so I'm so glad he could join us in person to have this discussion as we're thinking to the future. Madame Nwaina is supposed to join us. Not seeing her on the Zoom, but maybe she's having some technical problems. But she is the health education coordinator. And then we do have Mr. Yakubu Bulama online. He's the projects and water program manager. And then we have Mr. Joseph Ansibas, who is the malaria projects coordinator. And so thank you all so much for joining. Let me change to the Zoom. Can you, hang on, let me make sure that the speaker is set. Can you say something, Mr. Yakubu?
I would say good morning. Here is the evening in Nigeria. Thank you for having me on the Zoom. It's a pleasure meeting all of you.
Awesome. We can hear you well. Thank you, Mr. Yakubu. Yes. Mr. Joseph, can you say hi?
Hi, good evening and good morning to you people. We thank God for getting this opportunity to join the Zoom meeting. It is our first time meeting with some other people, but we pray that at the end of the meeting we have a fruitful deliberation. Thank you for inviting us for this Zoom meeting. Thank you.
Awesome. Dave, did you have a few words?
I'm somebody's few words, but it's so good to be here. I want to acknowledge Teresa O'Brien, who is a nurse from Kenya, who was one of the early pioneers. GHM brought her to Nigeria and working with the LCCN healthcare system. That's the work that she started that we built on and around. So thank you, Teresa.
Thank you for being here.
Thank you.
Awesome. All right, so my first question is really around the Village Health and Development Committee. And I wondered if, Mr. Yakubu, you could tell us a little bit about how they are a big part of making this program successful, from your perspective.
Yes. Thank you for having me. If you can hear me well over there, the Village Health and Development Committee is an integral part of the model we are doing in the communities out in the villages. They are very and the most important because they are the committee that will ensure sustainability of the program over time. All the village workers are being selected through volunteer means by the community, and they work directly under the Village Health and Development Committee. Now, in all the villages we are participating, the basic idea is for the community to have education and own their health by themselves. And the Village Health and Development Committee are the ones to ensure that happens. Village health workers work directly under the Village Health and Development Committee. Right now, we have started in so many communities and expanding to other new communities. It is this Village Health and Development Committee that will ensure continuity in the old communities where we have started. And they will also ensure that all programs and projects so designed in the communities are implemented by this Village Health and Development Committee. From the Village Health Development Committees, we drive all the necessary projects that will be implemented in every community. So they are very important because we rely so much on them for continuity. Even if we, the health team, will gradually shift our attention to new communities, they will be the one to carry out most of the activities in the old settlement while we continue to expand to other new communities. So the Village Health and Development Committees are also volunteers. They are not being paid, but they are stakeholders that are formed in the community and well respected by the entire members of the community to carry out all the programs that we have on board.
That is awesome. Any question? I wanted to make this also like I asked a question and then the audience can ask a question. Any question for the team at this point?
How many are on the team, the committee?
The Village Health Development Committee. Did you get the
Well,
question?
Yes, I get the question. The Village Health and Development Committee number depends on the population of the community. So if the community have a lot of households, then the number of Village Health and Development Committee members will increase. But it's always an odd number, either from 5, 7, 9, and above, so that you don't have a problem when it comes to voting for a particular issue. So we really have these people on ground because they are the ones that we rely on, and we supervise whatever they do monthly through a monthly visit to this Village Health and Development Committee, and then give them training on their roles and responsibilities so that they don't infringe on the norms of the community, and what we are doing also will be in line with the cultural practices in that community.
Thank you.
Let me just give a little background. The first missionary in that part of Nigeria was a doctor by the name of Niels Brahman. He arrived in Adamawa in 1913. And medical work became very important as the church grew, health and education. And over time, with the help of the Danish Sudan Mission, they developed a very effective and well-respected healthcare system in Adamawa. But as the system developed, as the church grew, missionaries gradually left. Now, health work was heavily subsidized by the mission. So when the missionaries departed, all of a sudden, there was a financial crunch. Some of the nurses who were working in the hospital, LCCN hospitals, then left and went to government hospitals where the pay was better. And there was a period of time in the late 80s where then just the number of dispensaries, health posts decreased. They were struggling. And when we arrived in 2009, 2010, LCGN healthcare system was really struggling. Now the Danes had also tried to introduce community-based primary healthcare, what our people here are talking about. They trained village health workers to work in the health posts. But rather than going out into the community, where they were supposed to work in disease prevention and simple cure, they became simple dispensers. And there was no community work. The other thing to understand is that there's good research now, which shows that the death rates of mothers and children under 5 does not change, is not reduced by institutional health care. A lot of lives are saved, but when you look at the broad numbers in the community, mortality rates don't change. If now you go into the community, like she's explained, those death rates drop significantly. Okay, that's
a great perspective. Yeah. And so my question, yeah, go ahead.
I have just one question too. The workers are chosen by the community, within the community. Just very briefly, what are some of the qualifications? What do people, look for? And how do they choose these women?
Did you get the question?
Not quite.
Okay, let me repeat it. So
Yeah.
in my presentation, when I gave the definition of a village health worker, I mentioned that they are chosen by community members. They're members of the community, but then they're chosen by community members. The question is, what are the qualifications? How are these village health workers chosen by the communities?
Okay, I need to correct this. They are not chosen per se, but if you choose somebody and don't have interest, then the work will not continue and it will not succeed. But they are volunteers. They have to indicate their interest that yes, they will commit themselves to become a village health worker, which of course they don't have any training, but they have been trained by the health team to be able to carry out all the intervention programs. Sometimes we call them change agents in the community because they are the ones that are trained by the health team without going through a formal education training, and they get an informal training on practical aspect of health services delivery and mostly prevention. So these village health workers are volunteers that are not being paid in any way, but they get incentives to be able to help them, sustain, increase the income generation of their household to get them going. Because in most cases, they leave their job to attend to women and people in the community. So I mean, while others are busy working on their farms, being farmers, these village health workers are busy taking care of the children and pregnant women and other people in the society, and they have less time to get to doing what they need for livelihood. So that is where the issue of incentive will come in, because they have volunteered and committed most of their time to working for the people in the community. So that's the real issue. They are not chosen by the community, but they give up themselves as a volunteer worker to sacrifice their time and energy for the community.
Thank you.
Let me add a little bit of the foundation of this again. When GHM arrived and basically signed an agreement in 2010, the agreement was that we would, first stage would be to develop a community-based primary healthcare model in the communities that could then be translated to the churches, dispensaries, and healthcare system. We wanted ultimately to have a healthcare system that would consist of a hospital, dispensaries, and community health workers. So we spent the first 7 years really working in the community, essentially in a pilot project, in 2 very poor, distant areas. That grew and succeeded, we learned, and now we're in the second stage. We're trying to carry this model now into the church dispensaries so that they can just rebuild the LCCN healthcare system on a community-based foundation. At the top, there's a health board, church health board. The dioceses also have health committees. But in terms of the health board, the next part of the team is the management team. And Balama and Antilas and Nuwaina are part of that team. And they're sort of provide general expertise, support. Then we have what we call mobile leadership teams that actually live in the community. Currently, we have 4 or 5 of these people. Their training is in community health extension. They actually live out in the areas, and they provide the on-the-spot training. But then village health workers are brought in groups to the LCCN hospital, where they provide further training.
Awesome. I have a question for Mr. Joseph, since you run the malaria program, and I wondered if you could talk about one story or maybe 2 that come to mind when you think about the villages and what difference it has made from your perspective.
Okay, thank you for giving me this opportunity to say something. The work of malaria started in the LCCN Health Services since 2012. We started the work in the community and the Women's Fellowship. Why we started the work within the women is, when you train a woman, you are training the whole nation. Because a woman can take a message from house to house. That's why we started training women during the malaria program. So, and the women that we train, they have to go back to their grassroots and also educate their people in terms of what causes malaria and how to prevent yourself from getting the malaria. Secondly, we give them net to distribute to the pregnant woman and the children under 5, so that they should not come in contact with malaria, because they are vulnerable to malaria cases, this kind of disease. Back to the CBPAC program, when we visited some village health workers, we organized a training as a team, health team. We organized training to the village health workers. We trained them what causes malaria, what are the signs and symptoms of malaria, and then how do you prevent malaria? So we train them on how to do rapid diagnostic tests, the village health workers, so that they can detect somebody who has malaria, and then they will give him malaria drugs. But if it is complicated malaria, we ask them to refer that cases to the nearest health facilities. But if it is uncomplicated, with the sign and symptoms that the patient presents to them, then they will now run the test. If it is positive, they give anti-malaria to that people. And then after giving the drugs, the next thing is that to educate the women that this is how you come in contact with malaria. Try to cover any open container in the house that will gather water, that mosquito will breathe there, and then mosquito will be in the community and it will cause some problems to the community. So the main issue is how they will prevent themselves from getting malaria. It's not a matter of even getting malaria, but our emphasis is to educate them how to prevent themselves not to get malaria. So by environmental sanitation, making sure that they use mosquito net in the night when sleeping, particularly children under 5, because malaria is too very serious in children under 5. These are some of the things that we normally do, and we continue to be doing it in our expanded community. Most of the village workers, they cannot treat uncomplicated malaria, and they can educate people on how to prevent themselves from getting malaria. These are briefly something that I can say with regard to malaria program in the health services. Thank you.
Thank you. Any other audience questions before? Yeah.
I'm trying to see what's the biggest challenge that those volunteers bring back to the supervisors, because I'm thinking because they have a first-hand look into the situations, they might have a different perspective. So are there some things that you didn't expect, but the volunteers bring back as one of the biggest challenges that they see?
Did you hear him, or should I repeat?
Well, I had him well.
Okay.
Okay.
Yeah, I think the biggest challenge is the issue of behavior change. It's really not easy to get the ideas quickly into the communities. It takes time before they get to understand how it works. And again, the terrains where we work are really difficult terrains, hard to reach areas, and there are also disadvantaged hinterlands. But still, we have to move in with Hilux vans that are now getting old or too old. Sometimes we spend the time on the road before getting to the communities for supervision. Such are some of the few challenges, but most of it is man-made that we can really get over it in the communities.
Did you have something to add, Mr. Joseph?
Yes, as you say, because behavioral change is a process. It's not something that you can wake up one morning and tell people this is what we want them to do, and they will do it. Gradually, you have to be educating them from time to time and try to tell them the advantages and disadvantages of everything. So gradually, they will now come to understand that yes, what you are saying is the correct thing. But you cannot come in the community one time and tell them that you should do this and the community will do it as the way you expect. But it will not go. But it's a gradual process. Behavioral change doesn't take time. It doesn't end at 1 or 2 days. It takes a long time, but you will not get tired of educating them. You will continue. It's a continuity, and then from there you start seeing the changes based on how they apply
one of the pilot areas, the communities that joined the program were about 14 when we started. But after some few months, 10 of them withdrew. Because what they were expecting was quite different from the model we have. So you can see, for them, it is a difficult thing to go by. After 3 years, 4 of them came back, 4 of the communities. And now gradually, almost all the 10 are trying to come back. Because now they can see successes in the communities that have continued with the program, a lot of changes, women getting educated. So, I mean, that at the beginning was a challenge, but gradually seeing has changed the ideas because there is progress in the participating communities.
That's awesome. That's really great examples there, Google. And
Yep.
I think one additional question from the audience. Go ahead.
So much of the news of Nigeria has to do with the conflict between Muslims and Christians.
Mm.
How is the buy-in with the Muslim community going? Has that been successful to bring together those two groups?
Did you hear the question?
But it is really at the back. Please
Okay,
repeat
I
it.
can repeat it. So,
And the accent is also,
yeah, so the question is that much of the news that we hear here about Nigeria, especially
Yes.
the northern part, is about the
Yes.
conflict between the Muslims and the Christians and maybe other groups. And so
Yeah.
the question is, how has the buy-in been from the Muslim communities in the areas that you serve?
oh, very good. I am now getting it. You know, this program is from the church as an organization, faith-based organization, and the church is only a window entry into the community. When we get into the community, it becomes a thing of the community. Muslims, Christians, non-religions are involved because healthcare is not a respecter of religion or whatever. So we now encourage all stakeholders and the imams and the pastors to start meeting with them and then try to get them understand that we are out for humanity, not for religion. So now they try to say, oh, this is not a Christian thing. It is a community thing. So the Muslims will now come and then we have meeting with them. And I tell you today, we have Muslims that are village health workers in most of the communities. They are also on the program. We invite them to training. They allow their wives to come and participate in the training, and they get back to their homes. There are one community in Waka area, they joined initially and withdrew because they said, no, this is a Christian thing. We don't have to be part of this. So when they saw the development in the adjacent community, they had water as an intervention, they had a lot of projects, malaria control, and all sort of intervention activities. They said, oh, now we understand it's not about Christianity, it's about humanity. And they came back. So I mean, the issue of Muslim and Christian and other non-religion is not quite a problem in what we are doing, because we will tell them that we are not out for a particular religion, but we are out for community members, for everybody in the community, because we have things to do with humanity.
That's a great response. And I think for me, visiting and being a Nigerian myself and living in the East for most of my life, you have similar ideologies about Muslim, Christian, and things of that nature. So when I was there, it was great to visit the village head, the Muslim leadership. All of them were there, part of the welcome committee. It was quite a sight for me, just to see everyone. So it truly is a community program. Both Muslims and the Christians and non-religious groups all come out, and they're part of the village health worker program. And it's such a unifying thing for the community as well. So healthcare can be a unifier because, again, healthcare doesn't ask for your religion. If you're gonna get malaria, it doesn't say, are you Christian or Muslim before you get malaria, you just get malaria. And so I think that idea has definitely made it more of a community program. And there's great buy-in from all groups. Rob, how much more time do we have?
Yeah, we can direct it to you.
Just one.
Maybe just do that and we'll try to wrap up.
Okay.
Hello, Bloma. How are you?
Do you see who's asking? I don't think you can see.
I have a question for
Yeah,
you.
I can see, but it's not visible. I can see somebody standing at the back.
Okay, hi.
Yeah, waving.
Yes, hello. Hi, Bloma and Antipas. How are you? It's Myla. So I have a question for you. I know
Yes.
you talked about the buy-in of a lot of communities, but what about the professionals, the health professionals within the community? How has their buy-in into this program been, the community-based? So we have communities of professionals in that area, like health area. Do you feel to see a lot of them are involved with these community-based programs?
Oh, is that Ismaila?
Yes.
Oh. Okay, fine. Ban ji ka sosai ba, but
Okay, Juma.
I think
My question is, we have professionals, we have health professionals in the system. There's a community in Nigeria, the part that we are in. How has the buy-in of these professionals, the health professionals, in the community-based programs?
Maybe I can repeat it too. So
Yes.
we've talked about the we've talked about the village heads being able to buy into the program and take ownership of it. So his question is, how about the healthcare professionals that are within the community?
oh,
How
good.
have they bought into the program, or have they not? What are your thoughts on it?
Okay. I think the professionals in the participating communities, most of them at the initial stage saw the program as quite challenging because we are involved in disease prevention, and they are in the health facilities waiting for people to be sick, and they go to them and they pay, and then they get treated. So gradually, in the professionals in those communities where we are participating, they begin to lose money because most of the people in the community no longer come as they used to come. Because any little thing about malaria, they will rush to the clinic, rush to any health professional. But today, they get education on malaria, personal hygiene, hand washing, that reduces a lot of illnesses in the community. We don't see them as enemies. We see them as progressive people in the community that we can refer difficult cases to. But they gradually saw the program as part of them because they are also community health workers. They are not medical doctors in the clinics. So they discovered, yes, this is very helpful. More so that when we have a pregnant woman that has some kind of complication and cannot be treated at home, our village health worker will accompany that particular woman to a health facility. And she will go together with the pregnant woman and she will introduce herself. And then they said, okay, now that you are trained and can be able to do this, just join us in helping the pregnant woman to get delivered. So they get involved, and now they have become friends. They don't look at each other as enemies any longer, because they do quite a lot to help in healthcare delivery system.
It's helpful to understand that the community health program works very closely with what they call the local government authorities, the LGAs. It's the smallest kind of division in the state. So in each LGA, there's going to be dispensaries and health workers, an immunization program, And our people work very closely with the LGAs, particularly in promoting immunization, for instance, prenatal care and delivery babies. When you go to the higher level, it's very similar to around the world. There's all sorts of documents filling the files about community-based primary health care. And people will talk about it. But when it comes to spending money to implement it, it all goes to hospitals. And what we're trying to do is to say, show, prove that if you want a truly effective healthcare system, you have to do both. There has to be a sharing. It's a balance. We need hospitals. We need tertiary care.
No.
But if that's tipped away in that way, mortality rates for women and children don't change. So we want to level the field, and that's growing. So we are prophets in this essence. LCCN is being a prophet to the state of Adamawa, and people are beginning to take notice.
All right. I would ask our friends here to join me. The word is Nigode. 1, 2, 3, Nigode. Please join me with our special guest.